Welcome to today's Forks Over Knives webinar called The Hidden Truth About Cholesterol and What Your Doctor Didn't Tell You. We have an incredibly special guest today with us. It is Dr. Columbus Batiste. How you doing, Dr. Columbus?
I'm great. It's good to be here. Good to see you again.
Yeah, it's great to see you. It's always great to see you.
Yeah, man.
We have an action-packed presentation today. And for those of you who have never heard Dr. Columbus Batiste talk before, he is a wealth of knowledge and he is an incredibly smart cardiologist. Today's webinar is all about cholesterol and some of the things that you may not know about the way that cholesterol can actually increase your risk for heart disease. And Dr. Columbus comes prepared with a whole bunch of information, and he really makes it very understandable for everybody. So it's the first time you've ever heard him talk, then I think you're really in for a good treat. So he's actually, truth be told, I'm going to brag on your behalf if you don't mind here for a second.
Uh-oh.
He's one of the.
How much money did I give you?
So, I'm on his payroll, so don't worry. Dr. Batiste is one of the top interventional cardiologists in the world. He's an assistant clinical professor at the University of California, Riverside School of Medicine, and the regional chief of cardiology for Southern California Permanente Medical Group. In other words, Dr. Columbus is kind of a big deal. So he's going to be here with us for the next hour, sharing everything that he knows about cholesterol so that you guys become as good of a cardiologist as he has become over the last 20, 30, 40 years. So here's what we're going to learn today. Number one, the role of inflammation in coronary artery disease. Number two, the many meanings of the term cholesterol, because it's a term that just kind of gets thrown around and we have to be very clear about what we mean. Number three, tests that you could and should be asking your doctor about. Number four, foods that have the biggest impact on lowering or raising your cholesterol level. It's good to know both sides, what can keep it down and what can drive it up. We're going to be talking about supplements in heart health and then a whole bunch more. We're also going to have a Q&A at the very end, and we would love for you guys to stay there so that if you have any specific questions, you can ask him and he can get your answers, your burning answers, ready for you. So before we go too far, if you have a question that you would like answered in the Q&A at the very end of this webinar, go to the Q&A box that's at the very bottom of your screen. There's a chat box and there's a Q&A box. So if you have a question, put it in the Q&A box and we have a team in the background who's going to be reading all these, and they're going to try and put together questions that we can talk about at the end in the Q&A. And then when you're in the chat box, I see that there's already a lot of you who are very active. Go ahead and tell us where you're from. And what I always love to know is if you are already plant-based, just put a number 1 in the chat box. If you are not plant-based, put a number 2 in the chat box. And if you're somewhere in between, then put maybe like a 1.5. I see lots of 1s and a bunch of 1.5s coming in now with a couple of 2s. So if I had to use, I cannot read this fast. That is unhuman. But if I had to take a stab at it, I'd say the average is probably like a 1.4, maybe like a 1.3. There were a lot of 1s to begin with, and now there's more 1.5s. And then there's definitely some people here who are not plant-based, which is totally cool. And, you know, this is going to be beneficial information for everybody, regardless of whether you already are or not. So let me show you guys here one thing. I just wanted to kind of do a couple of quick housekeeping things before we get too deep into this, to make sure that we are all on the same page. So let's see here. Give me 1 second. Here we go. A lot of people ask these questions, so I just want to get it out of the way. Number 1, yes, the webinar is being recorded. In a couple of days, we're going to send you the webinar replay via email. So if you have to miss something for whatever reason, or if you miss something, it's okay. The recording will be sent to you. In the chat box, please be kind, please be respectful, please be casual to one another. We do not want any insults, any negative comments. If we see any of that, we're going to take you out of the webinar immediately. And number 3, like I said before, put your questions into the Q&A box, and we'll try and get to them at the very end of the webinar. So now that we got that out of the way, we can have some fun. For those of you who don't know who I am, my name is Cyrus Kambata. I have a PhD in nutritional biochemistry. I have been living with type 1 diabetes for, at this point, it's actually 21 years. And I transitioned to eating a plant-based diet in the year 2003 when it was not cool and nobody I knew was doing it. And it's literally probably the single greatest decision, the second greatest decision of my life. The first was marrying my wife, Kylie. The second was eating a plant-based diet. And I am so moved by it and I'm so changed from the inside out that I decided to switch my entire career to teaching people how to make the same transition to reverse many chronic diseases. So if you guys have already felt something similar, I love it. And I want to be able to help. Dr. Columbus and I are here to make sure that you guys get all the information necessary so that you can also make this change if you haven't already done it. Now, the last thing I'll say here before I turn it over to Dr. Columbus is that we have another special guest here. And he is here off screen to share some of the information about the Forks Over Knives that the Forks Over Knives team has created for you. His name is Stephen Smith. He is the Forks Over Knives Customer Success Manager, and he is going to share some information with you about the Forks Over Knives Meal Planner. So let me just turn it over to Stephen here. Hopefully he's here, and we can take it off.
Thank you, Cyrus. I am so glad to be here with you and all of our wonderful friends out there. Hello. I know you're all excited to hear all of the great information coming up in today's webinar. So am I. But first, please allow me just a couple of minutes to tell you about one of my favorite things. Here at Forks Over Knives, one of our main goals is to make healthy eating easier for everyone. We know that adopting a whole food plant-based diet can result in many positive changes to your body and mind, and we have a lot of great tools to help people at any stage of their journey. Our most popular tool is our online meal planner, which you can try free for 2 weeks. So please come along with me for the next couple of minutes because I'm going to show you exactly what the meal planner looks like on the inside. Are you ready? Let's go.
Let's do it.
The first thing you'll do is select your goal. This is most helpful for the team to know. Then select how many people the plan will be for. Are you cooking for yourself, you and a partner, perhaps an entire family?
Sorry. I think some of you may have lost sound, so that is my fault. Let me see if I can get Stephen back here. I think there's an issue. Give me 1 second. Let's try it one more time. Okay, here we go.
Let's log in. First thing you'll see is your meal planning dashboard. Every week, the chefs at Forks Meal Planner will send you a 5-day meal plan with recipes that can all generally be prepared within 35 minutes or less. You'll see that there are already many delicious recipes added for me here, and there are more inside the recipe box that I can choose from. Over 1,500 right now. Here's the grocery list. It has all the ingredients I need for my meal plan this week automatically added. So I can go ahead and check off any items that I have on hand already, and when I'm at the store, I can easily access the grocery list on my phone or tablet to make my shopping super fast and easy. Here we go. So from here, we're going to move on to the weekend prep. And one of the features that I really think sets the meal planner apart is this weekend prep cheat sheet. You'll see that the weekend prep guides me through batch cooking, baking, freezing, speed prep with chopping and dicing produce, everything I need for the week ahead to greatly simplify my food prep and save time and money. And with one click, I can even print out everything into a handy PDF. My plan, recipes, grocery list, weekend prep, get photos in there if I want. Now there's plenty more to explore, but hopefully this gives you a taste of what the meal planner can do. So if you're considering joining the meal planner, or even if this is your first time hearing about it, be sure to take advantage of the 14-day free trial. Remember, there is no credit card required to try it out, and your account is free, so what have you got to lose? Head on over to forksoverknives.com/meal-planner. And that's how you can start your free trial now. My colleague behind the scenes, Brooke, has provided the link in the chat box for you too. I promise you will be amazed how easy and fun it is to create delicious plant-based meals every single day. So I hope you enjoy the meal planner. Enjoy the webinar first, and I'll send it right back to you, Cyrus.
Awesome. Thank you, Stevens. Thank you. Super cool. All right. So I hope you guys take advantage of that, because the Forks Meal Planner is truly incredible. It is a work of art. I've been using it for a long time and I absolutely love it. So now I will turn it over to the man, the myth, the legend, Dr. Batiste. You want to go ahead and maybe share your screen and start explaining everything there is to know about cholesterol metabolism.
Wow, the pressure, everything there is to know, huh? Well, the first thing I will correct is I will correct a mistake that Cyrus made. He said that his first greatest thing was marrying his wife. Second thing, going plant-based. I would change that, because he has a beautiful baby girl.
That is a good
And
point.
I would have to raise her up on there. I've seen pictures of this young lady, this future beauty. And so I would put her up high on that list. You decide one or two. I'll leave that debate between you and your wife. I know where she stands for me.
Can you see
Look
that?
at that.
That was
Oh,
this morning.
yes, I do. Yes, I do. Gorgeous.
Yep.
Gorgeous. I'm
Thank
so
you.
glad she took after her mom. Listen, folks, how are you doing today? We have a lot to cover. So Cyrus mentioned one of the things we want to do is we want to hit this hard and give you some information that you can hopefully take home. My goal is for each of you to become anointed cardiologists. My job is to knight you as cardiologists to gather information that can help you change your life and understand the questions. And so that's why I titled this, The Hidden Truth About Cholesterol and What Your Cardiologist Didn't Tell You, right? And so I'm gonna walk you through really what amounts to a patient scenario, a day in my life. And so this just happened actually fairly recently, right after Brooke and the team asked me to get involved in. I encountered a patient. And this is a patient who came to me inside the hospital and was having a heart attack at that time. And so what was so interesting about this individual is that he was 55 years of age. He looked younger than his stated age. He presented with new onset shortness of breath and some throat pressure, some tightness. He was 5'9", 163 pounds. He looked in great shape. His blood pressure was excellent. 108/69, heart rate was controlled, but note these symptoms. Underwent a stress test that was abnormal. We'll talk about that. And when I looked back through his chart, I saw his total cholesterol was 268. His triglycerides were 215. His LDL, known as the bad cholesterol, we like to call it, 178. And his HDL was 47 in that moment. So he was brought over before he reached me and had what's called a stress echocardiogram. And that's a procedure where we have you walk on the treadmill and begin to jog. And we use an ultrasound probe, like what happens with women when they're having babies, to look at the heart function. And we rotate that probe so we can look at every angulation of the heart. And so I don't expect you all right now, but soon you will be able to interpret this as well as I can. And so the top portion of where it looks like a donut, which you're not eating, it doesn't squeeze in real well. And so we know that there's some abnormalities with him in that moment. So we brought him over and I did what's called a coronary angiogram, which is what I'm trained to do. And this is a procedure where you enter into the artery. It can be in the groin or it can be in the arm. We insert plastic tubes just like a nurse places an IV. And from that, we pass additional tubes to the heart inject a liquid that allows us to take small movies of it. So we look at these arteries in different angulations, and I have the arrows that are pointing to areas of disease that he has. This first one to the left of the screen that has the double arrow is what's called the left anterior descending artery, also known as the widowmaker when it occurs higher up. He has a long area of narrowing. He has a branch coming off that highway that also has a narrowing. Another view demonstrates the second middle shot shows another artery that has a blockage, and the last shot shows the vessel on the right side with significant blockage. This man had 4-vessel coronary artery disease in that moment. And I remember he looked at me with shock and awe and dismay, as everyone typically does. And he was just befuddled. He was like, how did this happen? Who missed something? And he began to wonder, just like Tom Cruise inside the Minority Report. I don't know if any of you guys ever spend time out once you're done with Forks Over Knives and look at movies, Minority Reports, where Tom Cruise was a police officer. And his job was to go back in time to stop a crime before it ever happened. And a sort of play on reality, he said, I wish I can go back in time and stop this crime before it happened. So I began to look through his records, as I oftentimes do, and I recognized that 15 years earlier, when the man was just 40 years of age, he went in for a routine checkup. And during this routine checkup, his total cholesterol was actually higher. It was 294. His bad cholesterol, so to speak, was 214. Good cholesterol, 152, and his triglycerides were 145. But there was no mention of therapy at that time, or calculation, or a need to do anything in that moment. And it began to ask the question, what did his doctor not tell him? What his doctor didn't tell him in that moment? He didn't explain cholesterol to him. That cholesterol, we know, is not all bad news. We know that cholesterol is actually an important ingredient in the body. Right? This is how we make our cells. It's how we make our estrogen, how we make our testosterone. It's where our cells are comprised of for vitamins and mineral as well. We need this in order to perform. We actually do, in terms of bowel acids and so forth. But the question really comes up is that, so what's all the hubbub over? Right? And when should we begin the process of worrying about this? And so we have to understand that one of the first things that we do is that everyone should have their cholesterol checked and the right cholesterol values checked. And we're going to get into that. Roughly between the ages, if you're high risk, meaning if you have a strong family history of heart disease, you have really reasons to have concern, around 25 to 30. Females, 30 to 35. And same thing, if you're low risk, around at least 35. And females, 45 in men, that you should have your cholesterol checked. So my question to you is, have you had your cholesterol checked? Have you actually had this explained by your provider as to what's going on? Because we look at high risk factors, high blood pressure, diabetes, history of smoking, cigarettes and marijuana, family history of premature heart disease. These are some of the markers that in my mind as a clinician, I begin to think this is something, a red flag. I should look out for this individual and check. But the next question that he began to ask, well, what exactly, doc, is cholesterol? What is cholesterol, this thing? And when you begin to look at it, cholesterol and triglycerides, these are things we've all seen, like little fat droplets and oil on water. It kind of floats to the top, right? And these are insoluble, we call it, in water. And therefore, these lipids, so to speak, they have to be transported, especially transported in association with proteins. And these things are called lipoproteins. And so this is some of the terms you may have heard tossed about at times. And lipoproteins are complex particles, or these small structures. They have a central core, right, that contains the cholesterol to kind of protecting it, esters and triglycerides. And it's surrounded by additional cholesterol, phospholipids, and you may have heard this, apolipoproteins. And this is what facilitates transport and lipoprotein formation, this molecule as a whole. And so you have different sizes when you're looking here. So when we talk about cholesterol, it's heterogeneous. You know, there's different types that are there, some good, maybe some not good. It's almost like saying, well, let's look at the Americans. Let's look at the Germans. Let's look at the Finns. Let's look at the Jamaicans. Well, they may be heterogeneous once you go and start looking at the inhabitants of that country. And there's different types. And so same thing when it relates to cholesterol. These plasma lipoproteins, they're basically divided into 7 classes based on their size, right? You have chylomicrons, which was the ones I just described, real big and giant. And they're the ones that kind of transport the fat and the triglycerides around there. You have the remnants. Once they're broken down, then you have VLDL, very low density lipoproteins. You have intermediate density lipoproteins. You have low density, and you have HDL, right? And you have Lp(a), which many have heard about this recently here. And so if the ones that are the types that cause problems are your chylomicron remnants, your VLDL, your IDL, your LDL, your Lp(a) are all the ones, while HDL in some, in recent studies just told us that it's not in everyone, they actually help prevent the progression of atherosclerosis. A recent study out of the Regards trial made us start to question some of this long-standing thought process. And that's really one of the key things. As we go through, the key is that we continue to learn more and more and more. And as things are explored, we as providers have to learn. Your job as individuals who are patients, you need to also learn, because sometimes your providers may not be up on some of the information. So when we look at this calculation, a lot of times we don't actually test the true LDL. We're doing a calculation for an estimate of the LDL. And you just saw that there's different types of LDL, of cholesterol. And so when we're doing this and we order a test, and it's generally good for the masses, but when we need to break it down on a specific individual level to calculate the risk, we really do need to know the specific subtypes and subparticle types. And so we understand that. And so once again, we're looking at this total cholesterol is going to be a combination of your calculated LDL, your VLDL, and your HDL. So when you say, well, what is exactly my LDL, calculated LDL, is your total cholesterol minus your HDL minus your triglycerides divided by 5. Now, the problem is that if your triglycerides are very high, which oftentimes happens when you haven't fasted and you're eating a high consumption, or you're prone towards diabetes and metabolic disorder, which means your waist is a little bit big, the cholesterol is a little bit abnormal, your blood pressure is a little bit high. All these things, they add to the pot and make it very challenging. And the triglycerides tend to be high. They tend to parallel sugar and ultra processed food consumption. So when this is high, it throws off the equation that's there. So it's not a direct, this is where you may hear some particular information about the questioning the test itself. But when you dig in deeper into like, okay, well, how is the cholesterol really processed? These are things we have to think about. And we say, okay, when I consume fats, saturated fats, and so forth from animal proteins and fried foods and ultra processed, what exactly happens when it hits my stomach? So this is what we call the exogenous, meaning it arises outside, lipoprotein pathway. And this starts by incorporating these diets, these lipids, these cholesterol into what I described before, the chylomicron, right? That's over here, under where it says lymph. And then what that does at that point in the intestines, it goes through the circulation, and the triglycerides, the TG, right? It's then going to be carried in the chylomicrons, and it's metabolized in the muscle and adipose tissue, the fat tissue that's there. So the heart, all these areas, it's going to be metabolized through this, through your lipoprotein lipase, and it releases fatty acids here. To as well, which are metabolized further at that point. Then these are broken down to chylomicron remnants. Recent studies told us that these are very atherogenic, which means that they promote this plaquing, the hardening of the vessels. They promote this invagination that begins to happen. And these are some of the aspects. And so when this whole process just continues, if you start here roughly around 10 o'clock, where it's the normal vessel, and you start going through diffuse intimal thickening. This is the lining of the vessel called the endothelium, the intima, the intima and the media, and the adventitia. And as you begin to go that route, you get diffuse intimal thickening. You get this deposition of all these particles, apolipoprotein B. You start having the activation of the monocytes, which means the inflammation begins to happen, like a pimple begins to form. The fatty streak begins to occur. And so as you move over and you're back over around 6 or 5, you move here, you're starting to have the beginnings of atheroma. It's starting to build up, that's there, before now it's starting to invaginate as it gets bigger and bigger, before now it's a complex lesion that makes it prone towards erupting. And so these key initial events are the things that are the process that lends itself towards the development of coronary disease and symptomatic events itself. But here's the key, right? So we understand we have these arbitrary values that are there, 200 and so forth, and some of which are based upon research. But when we really dig in and look at this, We know if we start like from the area of the newborn, Cyrus showed us a beautiful pic of his daughter and so forth. And when she was born, every newborn, your cholesterol, your bad cholesterol, the LDL, the true LDL is low. It's markedly low. But as those values begin to rise throughout the time, as we ingest and as we have the various events, so does the burden of vascular disease. We start to see that this begins to spread at each incremental level. As you move from 50 to 60, which now the goals at European Society of Cardiology are to have the LDL down around 55 or so. All the way up to 70, which is where we promote it for individuals who are diabetic and or have had heart-related events. We see that there's a slow upward tick in progression that is a marker as well for atherosclerosis. So we know these numbers are real. It's important what the literature tells us. But here's one of the key things. There are some individuals who are born with a genetic predisposition, and they have a defect that lends them towards high cholesterol levels and atherogenic cholesterol levels at an early age called familial hypercholesterolemia. And when they have this, their occurrence right here, this demarcation of a heart attack, this happens at a young age. As you go lower and lower, where your cholesterol levels stay low, we look here that your event rate drops down. The likelihood of you having it when your lifelong LDL is low and your genetics are low, for that, you're less likely to have an event, meaning a heart attack and stroke, peripheral vascular disease, if you're able to maintain that. We know that nutrition plays a role, and we're going to talk about that a bit more. Just more about the importance of it. Here's one of the things is that it ages you. There's so many things that age you in life. We look here. So check this out, and I'll read it for you. When you're 20 to 29, this is where your bad cholesterol LDL is less than 130 to 189, greater than 190. Remember my patient, his cholesterol was over 200. When you are in your 40 to 49, your risk level of 13.1 is nearly the same, if not a little higher, than when you're 60 to 69. That means that it actually accelerates the occurrence of coronary heart disease by nearly 20 years. That means your vascular age is that much older, which is why it's so important to have a perspective of what your cholesterol, the true cholesterol numbers are doing, as well as what your blood pressure and diabetes rates. Same for women. It's actually a little bit higher. We're seeing that 20 to 30% rate of increase. We look at the incidence in comparison when your cholesterol is your LDL is over 190 compared to the cholesterol being less than 130, not even at 55 or 70, like I mentioned, just less than 130, we see a marked difference in terms of outcomes in the occurrence of disease, which is why that individual's coronary artery, to my trained eyes, look like a person far advanced in age with severe with severe comorbidities, which means diabetes, high blood pressure, et cetera, which he did not have any. So when we look at this overall, setting the stage, as the concentration of this thing called LDL increases to the left of the screen, right? It increases as you have this circulating in the body, the more likelihood you're going to have it retained in the vessels, the more likely you're going to have plaque development that's there. So we understand distinctly that this idea of high bad cholesterol LDL greater than 190 is a predisposition. It increases your lifetime risk of coronary heart disease. But really, what should cardiologists do? This is why I'm putting these slides up. This is from the American College of Cardiology. So this isn't Dr. B making stuff up. This is actually kind of how we go about it. And we're going to dig into the food shortly. But as I'm seeing this patient, I told him the first thing that your doc should have done is calculate your actual risk. See where your risks are. There's 3 things that we should do. Calculating your risk is one of the first things that we should do. Every doc should do this. So what do I mean by that? Well, there are scoring systems. You can actually download this on your phone, and it's called the ASCVD Plus Risk Calculator. It takes into account your age, your sex. Now, I'll be honest, this isn't the point of the talk here. I actually disagree with having the idea of having a race and ethnicity inside of here, but really more so it's important about social determinants of health, which impact everyone in different demographics. And it's burden of risk in terms of where you live, work, play, and pray becomes so important. Looking at your cholesterol values, your blood pressure, your diabetes, smoking, and it generates a number. And that number that we're looking for is 7.5%. Now, how did they come to 7.5%? Well, surprise, surprise, it was based upon the application of events, meaning the number of times the risk of having a heart attack is 7.5% over the course of 10 years, but also the juxtaposition with the number needed to harm. So we have something in medical literature called number needed to treat, which means the number of people I need to treat to see a positive effect and the number of people I need to treat before I see harm. And they want that to be markedly less than 100, which is somewhat of the medical standard that we have. And that's how that number was achieved, because that was based upon the use of a high dose statin is how they came to that. We want to be able to do this for sure, if we can, without medications. And so this is what my patient asked. He said, well, doc, I'm still not sure about the meds. I wasn't sure about the meds. If a patient comes to me and they tell me, doc, I'm not sure about the meds, my next step is to look, well, what are their other risk factors? What we call these risk enhancing factors. And you can begin the process of thinking about this as you're going through. What are the other things? So yeah, my number's high, doc, but what else should I do? Well, do I have a family history of premature heart disease, meaning that I had someone in my family who had a heart attack if they were a man or a male identifier before the age of 55 or female before the age of 65? Do I have this idea of such a primary hypercholesterolemia, meaning that my numbers are high, like I mentioned, above 190? Do I have this idea of metabolic syndrome, which means my waist is a bit expanded? I'm having the blood pressure elevated, my blood sugar, my low LDL, HDL too as well. Do I have chronic kidney disease? Do I have an inflammatory disorder like psoriasis, rheumatoid arthritis, or AIDS? Do I have a history of menopause at an early age? Do I have any other MI of South Asian ancestry? Side note, I had a colleague just come to me, say, Columbus, hey, can you see me real quick? And he had just retired, phenomenal guy, phenomenal, intelligent mind. And so he came to my office and saw me, South Asian descent. And so we were talking. Of course, I talked to him about his nutrition and so forth and dug into things in depth. And we'll talk about that shortly. And he mentioned his symptoms. I said, we need to go ahead and do an angiogram on you. And when we went and we did the angiogram, we saw such profound advanced disease that I did not suspect. But I knew that he has that genetically there is a certain predisposition that studies have actually shown that began to raise my level of concern. And that level of concern should have been undertaken in terms of recommendations about lifestyle and or use of medications when appropriate. And so we look at these things: high C-reactive protein, elevated low P, low A, apoprotein B, some of the things we mentioned about too as well. So and part of this goes into is having a discussion with the patient about, should we use these medications or not? Statins or bowel acid sequestrants, Zetia, there's PCSK9 inhibitors, all these things we begin the process of talking about. And part of the reason why is because they're trying to figure out, they mean docs, they mean me, is that is there an association between lowering this cholesterol and cardiovascular risk reduction? And the answer is yes. There is an association between lowering your overall cholesterol, the bad cholesterol, and your markers, remnants, and events. But the question is how we have to go about doing that. And so we know when we look overall, after patients have suffered a major heart attack, when you look towards the left of this vertical line, the more it is to the left, the more strongly associated it is with favorable outcome. And that's what this is showing. Anywhere a range of 12 to 21% odds reduction of a recurrent coronary event. And so we use these different meds and so forth. And by doing so, we find one thing. We find that as you move to that number, like we told you, 70 and below, we use a certain probe down the arteries of the heart that we will go in and insert. And when we do that, we can actually get imaging of how the vessel looks. And we're seeing the amount of plaquing and atherosclerosis on there. And what the studies have shown is that you actually can have regression. So I know you've heard a lot of people have refuted, and they've asked questions about Dr. Ornish's study, the Lifestyle Heart Trial, or Dr. Esselstyn's study in terms of reversal and showing the benefits that are there. We've had studies for years about the use of pharmaceutical agents with imaging and showing and demonstrating a reduction in regression of coronary artery disease. So anyone who says regression of coronary artery disease is not possible is not familiar with the evidence that's there, right? And so that's why it's so important for researchers and scientists to continue to pour into doing research to prove the value that we already know, that there is power in our lifestyle and how we approach this as we begin talking. Because when we look at statins, the most commonly prescribed, we understand that there's a whole host of risk associated as well as benefits. So we have the benefits: decreased stroke, ischemic, 16 and 21%. Coronary events, 27%, 20% for non-fatal heart attacks and coronary heart disease, and decreasing the risk of revascularization procedures. But on the other side, we say that there's concerns really about cognitive dysfunction, about hemorrhagic stroke, about some of the other aspects of the liver too, as well, about diabetes, about muscle symptoms and disease. We begin to see these things. And so my patient was just looking and saying, I still wouldn't be quite sure, doc. I'm still not quite sure if I would have even wanted it at that time. And that's reminds me of another patient I had. And so this was a young lady. She was young, youthful, 60 some odd years of age. She already was a whole food plant-based eater. She ate fruits, vegetables, whole grains, beans, legumes, nuts, and seeds. She had her dietary nitrates. She was on top of it. She did yoga. She made sure she got her sleep. She did all the things that I recommend to people. I was really kind of just stumped what else to tell her. But she was referred to me because of a history of Lp(a), one of the markers of risk, and her cholesterol levels were through the roof. They were over 260. Her bad cholesterol was approaching 200 at this point in time, and she did not want to take statins. And so when in this moment, as you see, 267 triglycerides, 107, which tells you, right? It gives you a perspective in terms of her dietary intake. Her good cholesterol, 61, and at that time it was 185 was her LDL. Here's one of the things that you can do. If you do your your triglycerides divided by your HDL, that gives you a value. That's a cheap value that you can do irrespective. That gives you a sense of what your risk level is like. And so if you see that number is less than 1.5, you're in good standing. We know that the likelihood of you having an event is low. If it's above 2.5, that places you at a higher. Remember, triglycerides divided by your HDL. That gives you a sense there. So you can see that her numbers are clearly less than 1.5, which means it's good. Now, I didn't stop there. What I did in her particular instance, and we'll talk about it. So as we begin looking at through hers, and she said, I don't want to take the meds. As I went through her risk factors, I went through all these things, the risk enhancing factors. I said, well, the next step, let's get a calcium score on you. Let's get an imaging study of your heart and see if there's markers of atherosclerosis present already, even though you haven't had symptoms, because it's an asymptomatic disease. And so I also checked the C-reactive protein. And so the volume of a calcium score in identifying individuals, it can really help de-risk, lower that risk level down. And so it's rapid, it's low in terms of radiation too as well, and it gives us more information that we can use. So what happens when we look at studies with this? It tells us that if I'm considering a patient for a statin therapy, and like this patient was, and the 10-year risk is high, that if the calcium score over here to the left, this gray box to the left, is 0, 57% of patients had a calcium score of 0, that lowered her overall risk from 7.5 to 7.5 down to 1.5, which means there's no need to give her a statin. Consider it, reassure her that she needs to be on her way doing the right thing. And others, 43%, you see that it didn't really change the score. For those who had extremely high levels, we still find, like she did, the calcium score of 0, 45%, it lowered the risk. So we know that from a projection standpoint, there's a good opportunity that she will do well. I can never tell you 100%, but we're looking in terms of odds, and this is powerful. That's what I did with her. And so when we looked, her calcium score was 0. This is an example of one with a high calcium burden, and you can see the white areas that outline everything from the aorta to the actual coronary arteries in that calcium score versus to the left of the screen where it's 0. Her C-reactive protein was low too as well. So guess what we did? Nothing at all. Just encouraged her to keep doing what you're doing. And it was a fight because every doc who saw her told her to be on the statin despite the fact of what we saw in this moment here. So every physician should do the same thing. What's that? Perform CPR. Not the way you're thinking. They should, number 1, calculate. Number 2, they should personalize it towards you. And then number 3, look to reclassify. So you have the information and the tools necessary to decide what you want to do. But, this guy said, I'm still not sure because, I've been looking online and I heard stuff like, hey, there's a shocking truth about cholesterol and they aren't checking cholesterol. Cholesterol doesn't matter. Well, you're right. It's more than just cholesterol. 40 to 50% of individuals who have coronary heart disease and events, they have a total cholesterol level of less than 200, which means that around 200 number is very arbitrary. It's technically less than 150. And we know the bad cholesterol, as low as you can get it, up to 55 in the right situations. But it's not just that, it's also C-reactive protein, which is a marker of inflammation. And what we know distinctly is the higher your numbers, the higher your risk in related to events that are there, the higher your numbers for C-reactive protein. When they combine C-reactive protein with your bad cholesterol, low C-reactive protein and low LDL had the best outcome, but high C-reactive protein and high LDL had the worst outcome, right? It's not just your C-reactive protein marker of inflammation. It's also, say, from Journal of American College of Cardiology, our Bible, so to speak, within the realm there. What we found is that apoprotein B, also another accurate marker for mortality, very predictive in people who are treated for their LDL. It moves us beyond it. It's a more accurate marker of risk than your LDL. It's not that apoprotein B is not part of the cholesterol package. It's one that we're not checked. So the idea that it's not about cholesterol, it is about cholesterol in its remnants in the particle size, but we have to make sure. So the patient kind of went to me, he's like, but doc, what else could I do? Could I use supplements? And there's a lot out there and so forth. We look at supplements or things that we're adding in addition, and there could be questions about red rice yeast, which is basically a version of a low dose statin therapy. And it can actually be a little bit safe, but the problem is that we just don't know quite what the composition is of it. That's the hard part as it relates to it. And so when looking at these things, studies have shown that it might be able to result in some mild reduction, 10 to 15% in different trials for triglycerides, as well as your HDL too as well, and mild increase in HDL and mild decrease in your triglycerides, mild decrease as well in your apoprotein as well. So we do see some benefit that's there. Another supplement, bergamot, right? 500, 1500 milligrams can result in anywhere from 15 to 20%, 25% drop in cholesterol, but it also can cause your blood sugar to drop. Not as much robust trials on this, right, as it relates to it. Niacin, not very tolerated in patients. I've used this before, but also associated with not niaspan, but niacin, usually causes flushing and a lot of symptoms like that. 34% reduction in the composite endpoints when you're able to tolerate the high doses as it relates to the niacin as well. Other agents like amla, Indian gooseberry, right, show to be to make reductions in terms of many of the vascular profiles as it relates to LDL and total cholesterol and triglycerides too as well, in dropping those down. So in general, we know omega-3s from plant sources. When we look at ALA, been shown and demonstrated with heart failure reduction. We know in general it may be able to drop some of the triglyceride levels down too as well. But the real question is, can we treat our food with our cholesterol? And this is what I saw out to do. And I told him, I said, I need you to come to my cooking class. It's called the Cath Lab, Cooking Alternative to Health. Right. And so in this class, we focus on what you are eating for your health as opposed to what you're not. And then the funniest story ever happened was we're doing the cooking class and someone raised their hand. They said, Doc, there's no meat. Where's the beef? And so I thought it was a plant. I thought someone was giving me, they're like, and so we said, well, we're focusing on plant nutrition. They said, well, they began to describe keto and paleo and what their journey had been. And they said, what do you think? Now, I'll tell you, in the words of Dean Ornish, you have to lead with love as opposed to a hammer. And I told them I appreciated what they had done for their health to start off, moving away from the processed foods, from the fast foods. I said, but what's your real question? What's your why? What do you want? They want health, doc. What are you willing to do to get what you want? I'll do whatever it takes. What won't you do? And I began to share with them the data that showed the correlation between saturated fat, which is primarily found in animal protein, and the increased burden on cholesterol levels. I began to share with them how it impacts the gut microbiome. I began to describe to them how it impacts the endothelium and leads to constriction of the vessels as opposed to dilation and stunning and damage, which causes problems. And they began to start slowly understand. And so we began to share recipes from that moment. And we started off with a chia oatmeal pudding. How this looks good, doesn't it? For those of you who haven't had breakfast at all, with berries and a few pieces of walnuts inside there. And you begin to break this down and you realize that pooled analysis showed that oat beta glucan, right, that lowers effectively your LDL and non-HDL cholesterol, as well as apoprotein B. And this leads us to kind of believe that we understand, multiple studies have told us it's one of the best forms of fiber that we can intake on a regular basis for lowering our cholesterol on a regular basis. And then we look at the berries. And we look at this soluble fiber that's there. And so we understand the benefits on our memory. We understand the benefits as it relates to our metabolic syndrome overall. But it's an interesting study out of China that looked at individuals who consume fruit 6 to 7 days per week had lower levels of high triglycerides, dyslipidemia, and hyperlipidemia compared to fruit consumption that was low. Now, obviously, there may be other confounding factors in there in terms of the foods you eat. This is one of the practical premises for individuals who are new. Focus on what you are eating for your health. Focus on foods that you have no dispute that they'll add value to your health. What do you want? What question are you asking first? If it's health, what am I doing for my health every single moment of every single day? What about almonds and walnuts? Well, almonds too as well, small amounts, 3 tablespoons, raw, unsalted, unroasted, right? I'm not talking about any of these other things. They've been shown actually to reduce LDL and maintain your HDL. So it's weird as we begin to look at some of these things, especially in the South Asian dietary group too as well, racial ethnicity. We also see too as well with walnuts that they've shown too as well interventions to American and Western diets that triglycerides reduce and your LDL also reduces, and that the apoprotein B levels were also reduced with walnut enriched diets. Remember, it looks almost like the brain, so it's rich in omegas too as well. And so this becomes powerful, not in large amounts, but for sprinkling or adding to as well, it can provide you value. What about chia seeds? This ALA may have some benefits as it relates to your lipid profile, your LDL, as well as your total cholesterol level. This becomes important for our overall well-being. I moved on to, we started cooking a nice meal too as well with some nice grains as well as cruciferous vegetables and broccoli too, as with broccoli and some tofu. It's what we made inside our cath lab because we like the meals to be tasty and good and quick. And so when you look at that, start breaking down how soy protein at a small dose of 25 grams per day, which is not very much, right? During a median follow-up of 6 weeks, decrease your LDL by 4.7 milligrams per deciliter, 2.8 decrease in total cholesterol, 6.4, compared to those who are in the non-soy protein group. There's power in the foods that we eat. What about our green leafy vegetables that we add in here? Our broccoli, our kale, our Swiss chard, our bok choy, the arugula, all these things that we begin to add. Well, these are soluble fibers, similar to like legumes. And so they've been shown to decrease your LDL. And so exploring this, we starting to uncover a lot of things that there are certain components. Your vitamin K plays a very substantial role, K1 and K2. And studies have shown that it decreases the overall atherosclerotic burden that's there when we do look at associations between vitamin K intake and both the atherosclerotic cardiovascular disease, ischemic stroke, peripheral arterial disease, and ischemic heart disease. How does it do it? We know that one of the ways steam cooking significantly introduces that bile acid. One of the ways in which we treat triglycerides through collards, kale, mustards, broccoli, bell peppers, cabbage. I'm getting hungry right now. I haven't eaten quite yet. Observing. And so we see these things begin to happen and the value is there. The binding value is there. It tells us about the rich antioxidants and decreasing. Here's the other catch, that K2 and K1 have been shown to decrease the hardening of the vessels, that calcification, and regress that too as well. So it's no surprise my patient who's eating robust amounts of green leafy vegetables was seeing benefit. Well, what about the grains like brown rice? Well, when we look at blood concentrations, fasting blood glucose, fructosamine, cholesterol, triglycerides, they all improve with pre-germinated brown rice diet, which pre-germinated just means that you soak the brown rice, which we do already. But I love using colors, red, black, brown rice, because the more color, the better, the richer the fiber and the phytonutrients for you. What about the superfood in beans, right? We understand, we look at blue zones and most long-lived. Very common theme is consumption of legumes and beans. And we understand once again that we saw significant reduction in cholesterol and your bad cholesterol with consumption on the large scale with this. They provide a nutritional metabolic cardiovascular disease. We see it as well. Lowering of the meta-analysis have told us about this pulse intake, reducing our overall LDL cholesterol intake, just 3/4 of a cup a day, 1 serving. Just have it. Add silken tofu to your smoothies. Have a piece of tofu there. Have some lentils, have some red beans. But let's put it all together briefly. right? It's like a true chef in the kitchen, in the cath lab, just like a portfolio. We want a portfolio. If I'm investing in my portfolio and my investment for my retirement, because everything you do part of life, you're investing in your health future. You're investing in your why. And so you can live the life you want to live in the future. And so you need to diversify your portfolio. But when you find something that is a high earning yield, you're going to pour more money into it, won't you? If you know that you're going to get 20%, 25%, 50% when you invest, you pour more into it. That's what we need to do with nutrition. We need to understand that these foods that we identify, focusing on what we should be eating, forget about labels of being vegan or this or that or the other. Focus on foods that are rich in fiber and nutrients that can transform your life. And the wonderful work of docs showed in the portfolio study, trial, is the fact that when they begin to engage and put patients on this intensive dietary portfolio of all the ingredients I just mentioned to you, oat bran, beans, almonds, plant sterols, green leafy vegetables. This is part of the portfolio diet by David Jenkins. And so as you begin to apply this, we saw a substantial drop in the LDL cholesterol, that low dense lipoprotein, that when they begin to apply this summary across different groups, what they found is that, yes, indeed, everything to the left of this straight vertical line means that it's extremely favorable where that dot is. So whether or not we're looking in relationship to lipids and your total cholesterol and your triglycerides and your HDL, we see a beneficial effect here. We look in terms of apoprotein B, we see a beneficial effect. We look in terms of blood pressure, and we look in terms of all these different things, inflammation, C-reactive protein, we see a beneficial effect as it relates to adoption and moving over. Now, you may say, well, why didn't body weight change? Because part of the trial was to make sure you normalize for the body weight, that they didn't want to account that everything was from weight loss. So they made sure the caloric intake was comparable inside these individuals. And so as we move further, we see that another study. Why do I have Houston? Because the study took place in Houston. I'm not a Houston fan. I'm a Dallas Cowboys fan. If I follow football, I am a staunch Cowboys fan. But when you look at this intervention done by Baxter Montgomery and his group, and what they found is they put patients on a very intentional, I would say they almost put them on a Cyrus type of a plan. They went hard in the paint. They gave them vegetables, fruits, whole grains. They made sure they were very meticulous in the foods that they ate. And when they did that, they found reduction in LP(a), total cholesterol, LDL-C, your HDL, triglycerides, apoprotein B, the particle sizes, small dense LDL, HDL2 as well, apoprotein A2. They saw a reduction across the board, which gives us hope. This is a small sample size. It needs to be replicated on a larger scale. But it tells us that there is power in our choices. Another study that was done out of New York that showed that when you begin to adopt this plant-based diet, a vegan diet, compared to having the standard American Heart Association diet, that all of a sudden we're putting out the flames of inflammation, and that we can actually douse that and lowering our C-reactive protein substantially compared to the group that continued to eat what was purported as a healthy diet. We look at this overall. Once again, same sort of scenario. We're seeing on a regular basis, we see these subgroup analysis tell us about your LDL, your non-HDL, your ApoB, all improve with the benefits of a plant-based diet. Wrapping things up, we see here in recent meta-analysis just came out from European Society of Cardiology telling us what I've already kind of outlined to you now. This part, our total cholesterol reduces significantly, our LDL reduces significantly, and our apoprotein B reduces significantly. There's power in the foods that we eat. You know, one of the things I finally told the gentleman who was in there is I told him as he kind of sat there just confused over what to do, and he finally said, I'm willing to do it, but I'm not sure I know how. I'm not sure I know how, doc. And I'm not going to spend much time on this today, but I kind of led him down a pathway, and I told him that he needed to get selfish. Get selfish. That's the title of my book, Spiritual. Studies have shown meditation obviously gives you focus for your plans that you have. That's there, strengthens your prefrontal cortex. It helps increase that the brain matter that's there. We see it too as well. We understand that it helps to drown out some of the noise when you look at functional MRI studies. We know that exercise, the power of exercise, raising your good cholesterol too as well. We know the power too as well of gratitude and forgiveness, that there's some studies that actually reduces stress, and stress actually increases the cascade of inflammation in your body, as well as with mobilizing the cholesterol. We spoke about food, which is the F. The I stands for intimacy of relationships, and studies tell us that loneliness propagates the inflammation cascade, which then leads to elevation in C-reactive protein, leads to interleukin 6 and tumor necrosis factor alpha. That we see this, that the S of sleep, lack of sleep, can also propagate the cholesterol to be raised through the stress hormone cascade too as well, and throwing off our intention to transform our diets. And last, the H stands for happiness. For laughter, for humor, and that humor basically can instill the body and enrich you. And what the studies have also demonstrated is that by doing that simply, you lower the stress hormones and you're improving overall. So this is a complete package. And when he began to adopt this, like many others, his cholesterol profile, this is an actual imprint taking out any markers of identification, showing that his numbers actually dropped down as he just started new on this process. He started this around May. So normally we like to check about every 3 months. He said, Doc, I want to see what's going on. His numbers had dropped down to 160 total cholesterol. Triglycerides 78 tells you he's eating well. Good cholesterol maintained itself. Bad cholesterol calculate was there. You look at the ratio, it's phenomenal. That HDL, the triglyceride ratio that's there. And so overall, there is power in your choices, power in your lifestyle. So when you're looking at steps towards lowering your cholesterol levels, the first thing is live a healthy life. Get selfish. The second thing, when you see your doc, say, Doc, I want to know what you find. Calculate my risk. Let's talk about risk enhancing factors. I need to have a calcium scan, because guess what? I'm a trained cardiologist. I got my degree from Dr. Columbus, and I've been knighted a cardiologist. I know I deserve a calcium scan. If my numbers are still high, I deserve to get a little bit breakdown on some of my panels that are there. And I won't tell you to start medications, but I will tell you that there is not a scarlet letter, right? That sometimes in the right situation, the right time, maybe not with cholesterol, but in other situations, don't say no, that I will never consider anything. But we want to basically, my wife says this, she learned this from someone in business. You have to inspect what you expect. So you expect health, you expect that you are living a life the way that you should in terms of what you eat and live and think and so forth, and how you act. You have to get your blood work done frequently. You have to get your blood pressure checked, your diabetes checked, so you can understand how are the effects of what I'm doing. Is this good enough? And when your doctor pushes back on you, tell them, say, Doc, I learned a long time ago from American College of Cardiology. Remember that the top 10 take-home messages, number 1 says that you're supposed to emphasize a heart-healthy lifestyle. All the way from the moment I'm born to the moment I die is your first step before doing anything else. And when you keep that at the forefront of your thought process, that's going to give you your best chance of what? Increasing your health span. None of us know today from tomorrow what our lifespan will end, but we can help predict, we can help impact rather our health span. So I know I gave you a mouthful. There's a lot still I could have gone through, but that probably, Cyrus, will have taken us out to about the next 2 hours, still going through every single nuance thing. But thank you all for spending some time, and I hope you learned a little bit here today, and that you're able to share information back to your friends, your colleagues, and your doctors as well.
Columbus, actually, your audio was off the entire time. Could you maybe start back at the top? We didn't hear anything you said.
No problem. I'll put my AI up and get going.
Put your AI robot back up. Okay, so first of all, phenomenal presentation. So many. I was learning a ton as you were going through this, because there were certain aspects of how to measure your cardiovascular metabolism that I was unaware of. So there were a ton of questions that came in, and there's a whole bunch of people in the chat box saying thank you. This is very, very, very helpful. So I want to kind of rapid fire through a couple questions here, because there's a lot. One of the common questions that a lot of people are asking is, okay, cool, this is awesome, sounds great. Why are my triglycerides still high? I've been eating whole food, plant-based, no oil for 2 years, 3 years, 6 years. Why are my triglycerides still high?
Yeah, and sometimes I get that question. I mean, as it relates to some individuals, and that's where you're going to have to get the subparticles, right? To really break down how we need to impact this as a general. Because we're not unique, we're not all the same. And so I get that occasionally where it's in part with if it's not solely what we're ingesting, it's what our body is producing. I would say when I've gone through, and I hope that individuals have really, when I've talk with patients, and I would probably say a good 3/4 of them, and I hit them with this, they're not quite as strict as what they say. And so I end up really trying to really hone in on every minutia, every single little thing. And so I think I love the planner for forks over knives, but one additional one that I'll give you, that I challenge you, that I usually will tell people who ask me and speak to me personally, is I'll say get something like MyFitnessPal or something comparable to that, and record every single little thing that you put in your mouth, everything. From your coffee, because realize coffee can especially over 3 cups can move your cholesterol levels up too as well. If you're adding in creamers, things of that nature, especially if there's anything sugar, I would then begin the process of honing back, and Cyrus, don't beat me up, to making your food primarily consist of what? Of berries, your fruits, as opposed to other types of fruits, and seeing how that impacts. I would avoid all alcohol, right? At that point in time, because it may trigger the triglycerides to rise too as well. And I will begin that process as it relates to, so that would be my approach. That's a hard one. We would have to really truly kind of look into it on an individual level.
Okay, fantastic. Menopause. Is there a correlation between menopause and high cholesterol? AKA, once you've hit menopause, is it harder to lower your cholesterol?
Well, one of the things that we know, that's a great question. So one, I'll start off by saying, I don't know. What I'll tell you is I know that is a marker and a risk. We understand that there's a huge hormonal shift as it relates to the burden and the elevation period, because we see this considerably. We see it considerably as it relates to, that's why it's one of those things we call risk enhancing factors. When you have premature menopause, it increases your level of risk. That's not just because the known correlation with cardiovascular events, but also the cholesterol levels too as well. So we do see that there is a relationship. This brings up a point I have to kind of address real quick. I know we're going to rapid pace, so I'm trying to do my best to speak quick. Is that we understand that many people are intolerant. I had a patient just the other day who reached out to me and said, Doc, I don't know what to do. I know you're not seeing patients much anymore, but I need you to kind of help me out. And she said, I can't take anything. I had another stroke, and I tried your diet. I was really doing it, but I fell off the wagon. They put me on these meds, and I had a horrible reaction to it. First thing I did was I looked at her thyroid. Because a thyroid, a lot of times, a low thyroid function, hypothyroidism, it corresponds with elevated cholesterol. And guess what? Her thyroid was elevated, right? So I would begin the process of really getting with a doc who listens and trying to explore all avenues.
Wow, I did not know that hypothyroidism is associated with increased cholesterol. That's crazy. Okay. How do you raise good cholesterol? Is fish oil the way to do it?
So fish oil is not, and the fish oil, I'll tell you, has been through a whole spectrum in terms of just straight medical literature. From at first, it was the wonder drug. We just loved it. To all of a sudden, we realized that, hey, maybe it's not so good in terms of outcomes too as well. And in terms of some of it being rancid too as well, depending on where you purchase it. In general, when we're looking at raising the good cholesterol, yes, you want your omegas are going to help. Exercise helps too as well. This is where it becomes confounding. There was a recent data, and I know I went through it a little bit fast, that came out a year ago that really told us, it made us question everything we thought we knew about good cholesterol. And it showed that maybe it's not as good as we thought, especially for certain segments of the population, that it doesn't actually predict reduce events, and it's not a marker of increased events. And so we're still learning a lot more. And there are certain populations who have extremely high cholesterol and seem to be protective. You have others now that we're learning where it's different. But in general, historically, there's a paucity of data as it relates to a wonderful way from pharmaceutical that can increase the good cholesterol. But exercise may help.
Fantastic. Here's my question. Is there a correlation between cholesterol level and dementia in patients that are over 65? And I think the question is, if your cholesterol levels have been high for some period of time, does that predispose you or increase your risk for dementia?
Well, remember, so the answer is going to be yes, because we understand many parts of dementia end up being a vascular dementia, right, from small vessels. And we understand the vascular damage is going to be caused by atherosclerosis. So if your markers of inflammation are elevated and your true small dense LDL is elevated for prolonged periods of time, the longer you bathe inside of it, here's the key. So go back to like when we all had to do the Zoom before we could even get back in front of each other. There was all this fear that was pervasive, and we knew about COVID and so forth. And irrespective of your thoughts, one thing clinically we understand is that when you're in close proximity to the virus with a large amount for a prolonged period of time, you're more likely to become exposed and infected. The same thing translates over with cholesterol. The longer your body is bathed in it, which is why I fear so much for our future, our kids right now, with the way things are going, the obesity, their level of diabetes, their level of dyslipidemia, the longer they're bathed in it, the more likely and the faster they're going to have vascular disease, which then pertains to can end up in vascular dementia as well.
Yeah, right. I've heard this is your lifetime risk calculation, which is basically how high your cholesterol level, your LDL cholesterol has been, as an example, over what period of time. The two variables matter. The larger the area under the curve, the higher your risk.
That's right. That's right.
Yep. Okay, cool. Now, I think there's one or two more questions. Okay. ApoB, ApoB, ApoB. Is ApoB a better marker than LDL cholesterol? Yes or no?
Yes, it is. It is. But is it the only thing that you can test? So remember, I mentioned, I know I said a lot, triglycerides divided by HDL. If your values are less than 1.5, that generally is a good moniker in terms of your risk profile. Very reflective of that bad cholesterol and so forth, and very predictive. It may be the best predictor. It also equates like with metabolic syndrome. Is your ApoB? Yes. So we're finding out C-reactive protein? Yes. All these things. And so I think generally my approach is this, to be honest with you. If the numbers are just markedly low across the board, for the most part, I'm not really worried about it. So if I have someone whose total cholesterol is 120, their LDL is like 60, their HDL is like 40, 50, and their triglycerides are 80, am I worried about a whole bunch of subparticles? I'm really not. But if I have someone and I know they're eating horribly and their total cholesterol is 300 and this and that and the other, I'm kind of starting there first. I'm starting there with nutrition and trying to get them going first. And then it's I tailor it. I don't do it for everyone, but I'm very selective and intentional on who I will do it for, as I described in that example of the individual where it's like she warranted additional tests because I'm like, man, her lifestyle is incredible. I will be shocked. And I was so thankful for her that her efforts really paid off as it relates to what her calcium score looked like and how she was doing in general.
Absolutely. This is great. Okay. I'm going to have to say that, I mean, there's so many more questions we could go through, but I think we're running out of time. So what I'll say is, first of all, thank you so much for being here. Thank you for giving the presentation. There's a lot to learn when it comes to cardiovascular metabolism, because there's so many different particle sizes, different particle types, how they interact with one another. You take this one, you divide it by this one, you take this one, divide by this one. But I think the main take-home message, if we had to sort of summarize it in a word or in a sentence, is that your food matters, right? The quality of your food matters. The higher your intake of plant-based material, the lower your lipid profile is likely to go. Is that a safe statement?
Absolutely, it is. Absolutely, it is. And last, I'll add to it, thank you for summarizing that, is inspect what you expect. You expect health and wellness. You have to also inspect, you have to also go ahead and make sure you get tested. That's important. Make sure that you're staying the pathway you need to. Cyrus, you check your blood sugar. You're eating, you know what you need to eat, you know how you feel, but you aren't just saying, oh, I'm just going to go with the flow. I've been with you. You're like, no, let me see what's going on.
Seen it.
We need to have that same sort of mindset. And I'm speaking to myself. I'm looking at the man. I'm starting with the man in the mirror first to try and make a change.
Absolutely. So for also, before we leave, there's still 1,500 people here, which is fantastic. So for those of you that are still with us, don't forget what I talked about at the beginning of the webinar. Remember to go check out the Forks meal planner and start your 2-week free trial. There's literally nothing to lose in this opportunity. I've been using this app for a long time. My wife uses it. We get a lot of inspiration. and it helps you make your it helps you plan what you're going to get at the grocery store. It helps you batch prep, and there's nothing like it. It's really very effective at helping you organize everything there is related to food buying, food storing, food making, and food eating. So visit forksoverknives.com/meal-planner. You can see it in the chat box. Again, forksoverknives.com/meal-planner. Start your 2-week free trial today. And we will see you guys next time. Thank you one more time, Dr. Columbus. It's always a pleasure.
Thank you. And what we'll do too, as well as maybe since we're going to jump off of here too, as well as maybe we can aggregate the questions, and maybe Forks Over Knives will invite me back at some point in the future, and I can kind of give a follow-up with addressing some of the questions that went unanswered in the future.
I like that. That's a great idea. That's a great idea.
All right. Take care.
All right. Have a great one.
All right.